So what we're going to talk about this morning is resuscitative endovascular balloon occlusion of the aorta, which is something that we're interested in bringing here to Mount Carmel, and are in the process of that. In order to understand the context of this and why we're doing this, you also have to understand really the indications for and the performance of resuscitative thoracotomy. As REBOA kind of builds off of the resuscitative thoracotomy data and mindset, and as it kind of will not supplant the need for resuscitative thoracotomy, but will replace some instances of when we do resuscitative thoracotomy, and that'll become clear as we go along. So let's talk about resuscitative thoracotomy and the evolution of that, and why we use that in some instances here for a few minutes by purposes of introduction. The institution, if you will, of resuscitative thoracotomy as a tool in the setting of initial management of very severely injured trauma patient dates back to the days of some of our trauma and vascular surgery giants from Texas, Dr. DeBakey and Dr. Denton Cooley. And these guys were guys that not only were known to surgeons and to medical professionals, but these guys were actually household names throughout the country at this time. So groundbreaking was some of the things that they were doing in Texas in regards to cardiac and vascular surgery. And one of the things that they did was institute the use of resuscitative thoracotomy actually in the ED, which is something that hadn't really been done in any type of a standardized fashion before. And in their initial report, they were able to salvage 3 of these dead trauma patients, essentially, that had come in. So these are trauma patients that came in pulseless electrical activity, and they were able to salvage 3 of the 16. Obviously not great numbers, but again, when you're talking about patients that present dead, you know that is something that's worthy of notice. Now, this guy, Gene Moore, has been for 4 decades, as was his predecessor, Dr. Ben Eisman, kind of one of the voices of restraint and sometimes reason in trauma, though. And after some of the initial reports that came out of Texas, they said, well, yeah, this is kind of a big deal, though. You know, opening chests in the ED, it exposes people to infectious risk. You know, it is certainly a morbid thing to do, and it's expensive. You use a lot of blood products and things, and so we just need to be careful. They said because the majority of these patients, are not salvageable, and even if you do salvage it from a cardiac standpoint, how many of them actually regain any meaningful neurofunction? And that was one of their criticisms was, if you're not careful, you'll resuscitate these patients, but you're essentially resuscitating a comatose patient. And so even in the early years, it was recognized that there's a balance between when this should be done, and you do need to choose your patients carefully. So why do a resuscitative thoracotomy? What can you really do by opening somebody's chest in the emergency department? One of the main things you can do that can potentially salvage a patient is release cardiac tamponade. And we'll talk about that here in a moment a little bit more in depth, but the majority of the salvages that at least I've seen, and I think that most investigators and people that do trauma have seen, is the tamponade patient, because you can markedly improve the patient's hemodynamics and get them back from PEA a not insignificant amount of the time, up to, in some series, 50 to 60% of the time, with quick relief of pericardial tamponade. And that's one thing that resuscitative thoracotomy allows you to do more quickly than, let's say, pericardiocentesis, putting a needle in, which is another way to do that in less severe circumstances. It also allows you to facilitate internal compressions, which is, as we're going to see, more effective than external CPR. And what's going to be most salient to the relationship with REBOA here, it facilitates aortic cross-clamping. And that's really the component of this that REBOA can replicate. REBOA will not do anything to address pericardial tamponade. It will not do anything to allow you to do internal compression. So in these regards, when you need this, resuscitative thoracotomy still has a role. but where we think and where investigators are showing REBOA has an opportunity to improve the process is in relation to giving us a better way to facilitate aortic cross-clamping. Well, why do each of these things? Well, first of all, let's talk about how you do a resuscitative thoracotomy. You don't need an enormous amount of equipment. Essentially, you need the things here, something to open the chest with, something to spread the ribs with, and something to get around your aorta ultimately. You need to position the patient rotated slightly to the left. We have our ED colleagues get either a nasogastric or an orogastric tube down to distinguish the aorta, which is often flaccid in this setting if they're in full PEA arrest, and therefore difficult to feel. And you can injure the esophagus, and because it can be hard to distinguish the esophagus from the aorta in that setting. So having an NG tube down or an OG tube down is helpful. And usually I have a resident or an ED colleague or somebody or another attending putting a chest tube in on the right side as we do this. But basically, you just get the patient position slightly on the left or slightly rolled to the right, arm up, and then you can get to the left chest area quickly. You make your incision basically from slightly below the nipple here, and essentially from the sternum down to the bed. And then you're able to open up widely here. And if you end up having significant right chest pathology, you just clamshell across here and go into the right chest. Morbid stuff, but again, we're talking about patients that are on the brink of death or that have already died, and this is a last-ditch attempt to salvage them. So what do you do once you're in there? What does this gain you? Well, again, the majority of patients that are in PEA at least, or even sometimes in asystole that you're going to be able to salvage, it's going to be pericardial tamponade. It only takes a relatively small amount, 10, 20 cc's of blood in this stiff pericardial sac to give you basically obstructive shock, the inability for the heart to pump blood out of the heart due to the pressure that's against it, and therefore you have peripheral collapse. So once you've got your thoracotomy incision, the first thing we do is tent the pericardium up here, incise it. Here's the phrenic nerve, so you try to go anterior to that, open that up widely, and then you can get the clot evacuated, which will allow the heart to resume its normal function. It also very quickly gives you an assessment of how much blood's in the heart, and at this time, typically you've got somebody given blood rapidly through a rapid introducer, or through an introducer with the Belmont, and it gives you an opportunity to see how that heart's responding to that. It also allows you to do internal compressions, which we know that in the setting of trauma, external compressions aren't worthless, but they're pretty close. The external compressions in the setting of trauma have been demonstrated to exert only approximately 20% of normal pressures and will give you adequate perfusion for only about 15 minutes. It's a relative thing, depends on the size of the patient, depends on the person doing it. But this is kind of the time frame that lab models have demonstrated to be effective. On the other hand, internal compressions give you about 60% of normal aortic pressures, and which can bump that time by twofold, or can double the time that you can get adequate coronary and cerebral perfusion. So internal compressions. So the second thing that we do, or at least in the patient that's in PEA, if it's a patient that's profoundly hypotensive and you've done the thoracotomy for that, you don't necessarily need to do compressions, but in the majority of these instances, they're in PEA, you get in there, you evacuate, you open the pericardium, you get any blood out, and then after you do that, you assess where you're at, and you start internal compressions, and that's much more effective CPR than is external compressions. The third thing then that you can do is cross-clamp the aorta, and that's really what we're focused on here this morning, is the aortic cross-clamping, which can, basically what it does is it shuts off the blood supply to about half the body, and therefore the blood's having to flow to only half the body, and so you maintain better perfusion to that half of the body that you continue to perfuse, and it's kind of, you can argue, the most important half, your heart, your brain, and those areas that are necessary to have a neurologically functional patient after things. So what you do for this is basically, and this is after you've done these things on the heart and while you're continuing to kind of do internal compressions, you basically get the lung freed up here by incising the pulmonary ligament, and then push the lung anterior and superior and go down, and right above the diaphragm, the aorta will be here right in front of the vertebral bodies. You basically incise the posterior pleura around this, and then you're able to get your clamp around and cross clamp the aorta. And what that will get, and here's basically what it looks like. Here's your aorta here, here are your clamps, here's where your vertebral bodies are. It's kind of the initial landmark. Your esophagus is up here. And what this gets you is a doubling of the cardiac output and the mean arterial pressure in the setting of severe hemorrhagic shock. It also improves your coronary perfusion. At a significant expense, though, obviously you're not perfusing your things below the diaphragm, and so very quickly you'll get renal ischemia, in some instances spinal ischemia, depending on where the artery of Adamkiewicz is. The artery of Adamkiewicz is a real downside to cross-clamping the aorta in that it's an inconsistently located vessel that provides blood directly off of the aorta to the spinal cord. In some instances it comes off lower, other instances it comes off higher. If it's in an instance where it's coming off lower, you're cross-clamping above that, and you'll fairly quickly get spinal cord ischemia. So some of these patients will end up being paraplegic when you cross-clamp the aorta for an extended period of time. So you really only want to do this if you have to, and if it's if it's going to have a benefit. If you have, let's say it's a setting where you did have pericardial tamponade, you've got a hole in the heart, you don't cross-clamp the aorta before you fix the heart, because that increases the pressure that you're working against. You fix the heart, then you cross-clamp the aorta. So the initial cross-clamp the aorta is primarily for intra-abdominal injuries or other injuries below the diaphragm in a patient that's in extremis. But what it does get you is, again, improved coronary perfusion and a significant improvement in your cardiac output, because you've got less area that you have to pump blood to. But at a great cost to the kidneys and to other parts of the body. So you can't do this for an extended period of time. I really try to target having the aorta cross-clamp less than 30 minutes whenever possible. So this isn't a patient you're staying and playing in the ED. I mean, you're opening the chest, you're doing what you need to do, and the OR is ready, and you're up there, in a few minutes, typically. So what are the outcomes you can get with this? Well, it kind of depends on what you start with. And this is a study done by Dr. Boyd and colleagues, published a couple decades ago now in the Journal of Trauma. And you can see that if the patient has signs of life or has no signs of life, and what are signs of life? Respiratory effort, pupillary activity, a measurable blood pressure, and some cardiac electrical activity. Then if you have absence of that, both at the scene and in the emergency department. In this study, they had 35 patients. So the first block is the number of patients that they did an ED thoracotomy on with this setting. So you see 35 patients, no survivors. So those are patients you're going to seldom salvage. If it's questionable at the scene, and this is the most common scenarios you can see here, accounted for the majority of patients in this study, and they have no signs of life when they arrive, but it was questionable, somebody thought they saw something at the scene, 4 of those patients were ultimately salvaged, 2 of which had meaningful neurologic function, 2 of which did not. Patients that did have definitive signs of life at the scene, but didn't have them when they got to the ED, you can see a little bit better outcomes here. About 15% of those patients surviving, and about half of those with, good neurologic function. So not high numbers, but again, somebody who's dead that ultimately you're able to get back to their families and a meaningful life. And then if you have signs of life before they go down to PEA, both on the scene and in the ED, up to around 20% survival in this series. So not an enormous amount, but some patients which you're being able to salvage. You can see that the outcomes have improved over the years, different eras of doing ED thoracotomies here. Overall survival rates having improved from around 5 to close to 15% in the most recent series. Probably at least some of which is probably from refining our processes, some of which, probably more of which, is from more carefully selecting our patients and not being quite as big a cowboys in regards to when to do ED thoracotomies and when to refrain ourselves from them. So the Western Trauma Association a couple years ago published a really good set of guidelines as to when ED thoracotomy, looking at hundreds and really thousands of patients even across the country, multiple institutions in the Western Trauma Association coalition, demonstrating and showing which patients they were able to get to survive, looking at, again, presence like with the previous study of signs of life or not, but then also looking at how the patients present. It makes a difference in regards to whether, for example, the patient has had penetrating trauma or whether they have had a blunt trauma. Penetrating trauma patients, you're a lot more likely to salvage with an ED thoracotomy. At least that's what's been demonstrated in the past. Patients with PEA versus asystole, which do you think would do better? PEA, obviously, right? Asystole is a more morbid rhythm. So there was a thinking that, if you've got asystole, you should just call it a day right there and not even consider ED thoracotomy. Was that really true? Western Trauma looked at all of that, and what they recognized was that they did not see any salvages with blunt trauma if you had pre-hospital CPR for more than 10 minutes without a response. Ditto with penetrating injuries for CPR greater than 15 minutes. Within these time frames, or if they got a response, they did see, a number of survivors, or at least some survivors, and so they say it's worth a shot then. In similar fashion, asystole as a presenting rhythm, the only instances where they were able to demonstrate a survival was in the setting of pericardial tamponade. Hence their recommendations for limiting ED thoracotomy to patients that have pre-hospital CPR less than 10 minutes without a response, or less than 15 minutes for penetrating trauma. If the patient's been out for longer than that and they're not having any response, you call it. You don't do the ED thoracotomy. Under that time frame, or if you've got any response, consider doing an ED thoracotomy. If they're in asystole and they got a gunshot wound to the abdomen, you're done. No ED thoracotomy. There's not been any survivors looking at thousands of patients with that. On the other hand, if you think they've got a gunshot wound to the heart, stab wound to the heart, could be pericardial tamponade, worth doing, because there have been people that have had a functional survival. So that leaves you with this algorithm here, basically where you can see, okay, patients coming in, they're having CPR done, they come in, they've got no signs of life. What do you think about? How long have we been doing CPR? More than 15 minutes, you're done. Okay, more than 10 minutes with blunt trauma, you're done, because you've had no response. That patient's not salvageable, tragically, and you don't go through the resources and the potential risk to the team of doing the ED thoracotomy. On the other hand, if the CPR has been done for less than this period of time, or if you've gotten some response, then you move forward with the resuscitative thoracotomy. In similar fashion, if they've got some signs of life, some respiratory effort, or they've had a blood pressure response, then you go forward with the resuscitative thoracotomy in similar fashion. Okay, so now you're in the chest. What do? You open the pericardium, right? That's the first thing you do. Do we have tamponade? If so, evacuate it. What's the rhythm? If the patient's so do they have any cardiac activity? If the answer is no and they're in asystole, did you have tamponade? Yes. Okay, continue the resuscitative measures. If, on the other hand, they've got asystole and there's no tamponade, you're done. In the patient that has PEA, which is the more common, once you've opened and evacuating pericardium, you're doing internal compressions. What do you do next? Is there a cardiac injury? Yes, well, fix it. If there's thoracic hemorrhage, yes, control it. You're in the chest, so you should be able to get a vascular clamp or something on that and get to the operating room. Air embolism is something sometimes you can look in the coronaries and see air there. In those instances, you cross-clamp the hilum of the lung. That goes beyond the parameters of this discussion. We'll talk about that at another time. Do you have extrathoracic hemorrhage? So basically, most commonly abdominal hemorrhage in this setting. And if the answer to that is yes, then you go right to aortic cross-clamping. Again, if you've had a chest or a heart issue, you fix those, then you go to aortic cross-clamping to support. It doesn't make sense to cross-clamp the aorta before you do these things. And then at that point, you see what's going on with the patient. You're typically in the OR, and you go from there, and then you're into a different algorithm. So where does resuscitative endovascular balloon occlusion of the aorta come in? It basically comes in these areas which are highlighted. We're going to show not really as helpful in this setting. Certainly if you've got a thoracic injury If you've got a cardiac injury, REBOA is not going to help you. You need to be in the chest anyway to fix the heart, to fix the lung. So it doesn't make any sense to do REBOA in that setting, I would argue, and I think the literature supports that. Some people would argue against that, but for the most part, thoracic injuries, cardiac injuries, contraindication to REBOA. Where REBOA we think can be helpful, and where others are demonstrating it to be helpful, is in that patient that has essentially an abdominal or a pelvic source of their hemorrhage, which has caused them to either go into PEA arrest, or I would argue perhaps the greater use of it is just in that patient that's on the cusp of it, that's in profound refractory shock. And instead of having to open that patient's chest, geez, wouldn't it be better to have a minimally invasive way to get into the aorta, put a balloon up, and accomplish the same thing for these patients that you're able to do by opening the chest. So again, can't emphasize this enough, REBOA is not for thoracic trauma. So this is not a new concept. This was tried on several patients, actually by a forward-thinking surgeon, Dr. Hughes, pictured here during the Korean War era. Used this in 2 patients and was able to temporarily salvage them. Sadly, both went on to die, but he was able to demonstrate an improvement in blood pressure through this very early use of a balloon catheter. Not really too much more was done with that over the ensuing decades, really until the 1990s. And what happened in the 1990s was a paradigm shift in how we fix abdominal aortic aneurysms and both abdominal and upper lower extremity vascular issues. The first endovascular or EVAR repair of a AAA was done in 1991, and then literally the technology exploded over the next 10 years to as most, if not all of you know, it's now the standard of care. And so instead of going and getting a cross clamp above these bad aneurysms, the surgeons go in, and if it's a ruptured aneurysm, they get, guess what, a balloon upstream here, control the bleeding in the aneurysm that way instead of with a cross clamp, and then put this stent in. And with that, vascular surgeons have gained an enormous amount of experience with wires and endovascular approaches that we didn't have in the past. And so naturally, as people became more facile and more comfortable with this, people started asking, well, gee, are there other applications we could have for these skills that we have and the technology that we have? And even, could you basically, as a general surgeon, learn to use this technique and maybe get control of the aortic bleeding, prior to the vascular surgeon getting there. If you're a trauma surgeon in-house, somebody comes in with a ruptured aneurysm, your vascular surgeon 30 minutes away, it'd be great to have these skills as a general surgeon to get the balloon up, be able to control that bleeding, maybe save the patient's life, and then the vascular surgeon, arrives as you're doing that and gets things controlled. And this was just one study from some of my former colleagues in the military, looking at such an experience, and reporting on it favorably from Madigan. One of the, and so then it became natural to start to apply this same thought process to trauma. And one of the more forward-thinking vascular and trauma surgeons, I think, over the last decade is this guy, Todd Rasmussen. We labored over a number of the same patients when I was in my last tour in Iraq. I was talking with this guy on pretty much a daily basis back then. We basically even reported on the same group of patients. It's kind of a good lesson on how to do things when you're, I guess, trying to move up in the academic hierarchy. When we were talking about patients one day, I said, hey, we should report on these temporary vascular shunt patients, because that's what we were doing. We were doing this really in volumes that nobody had done before. Essentially, our patients would come to us in our forward resuscitative surgical system with very severe vascular injuries. We frequently had a large number of patients, and we were kind of in an austere set of circumstances, so it wasn't the best place in the world to do a definitive vascular repair, and we didn't necessarily have all the equipment or even sometimes the expertise for some of these injuries. So what we would do, and what we were one of the first ones to do in any type of volumes, was shunt these. We would go in, get the bleeding controlled, put these vascular shunts. You can see here, we've replaced the femoral artery, which was blown out here, with this shunt here. We replaced the femoral vein, which was blown out with this shunt here. get the patient stabilized, ship them to the next level, and then Todd and his colleagues in the more controlled circumstances at the 332nd EMG or at the 82nd cache or the 36th cache would do the definitive vascular repair once the patient was more stable, better able to undergo the definitive procedure in a place that had better resources, and they went on. And we were able to document these patients had, very good outcomes. And so I told Todd, hey, we should publish on this. Then I didn't hear anything back from him, and I'm like, uh-oh. So it kind of became a race, basically, where we were both trying to publish this experience first. And as you can see, although Dr. Feliciano graciously listed our paper first, Rasmussen beat me to it because he was a few editions earlier. So now every time anybody talks about temporary vascular shunting, his paper gets cited, not mine, so I'm still a little bit pissed off about that. But nonetheless, it was a good lesson for me in how to get things done, because I got my paper submitted earlier, but he got his paper submitted to a conference, and then it turns out if you get your paper presented at a conference, it gets published sooner. Lesson learned. Anyway, good guy, great surgeon, and someone who is demonstrates a characteristic I like, which is not being willing to accept an inadequate standard. And he recognizes that there's a real opportunity for improvement in management of these severely injured patients, potentially by applying the techniques used in vascular surgery, used in endovascular surgery to this setting. And with that, a number of experiences started to come out as they started to do this at a number of places. So Dr. Rasmussen, also John Holcomb, who was the senior trauma consultant to the Surgeon General of the Army when I was in, and somebody I corresponded with frequently back in my days in the military, have really pushed forward this concept of resuscitative endovascular balloon occlusion of the aorta, and have been supported significantly by Tom Scalia, who's nationally and internationally recognized leading traumatologist, works out of Baltimore shock trauma. And one of the things they did in this first paper, I think, one of the main things they did in this first paper was really establish where, if you're going to put a balloon up, it should go up, and essentially an area where you shouldn't put it up. There's this area basically where the mesenteric and the celiac vessels come off here and where the renal vessels come up. You don't want to be inflating a balloon here, because you'll essentially obstruct or disrupt the orifices of these very critical vessels. So this is kind of a no-fly zone where your balloon has to stay away from. But if you have patients that have significant abdominal hemorrhage, maybe even from one of these vessels, getting a balloon upstream from that, basically somewhere between the takeoff of the subclavian artery before the celiac trunk here, so somewhere in kind of the lower thoracic aorta, can be very beneficial. On the other hand, if you've got somebody who's bleeding to death from a severe pelvic fracture, you don't really need to be making all of this area ischemic by having a balloon blown up, here in the thoracic aorta. Hence the concept of a different aortic zone where it's appropriate to put a balloon up, zone 3. So they basically divided, or came up with this concept of dividing the aorta into 3 zones: zone 1, 2, and 3, with zone 1 being the area that you want to have the balloon in for abdominal hemorrhage, zone 3 being the area you want to have the balloon in for pelvic hemorrhage, zone 2 being the area you want to stay away from. And I think that was one of the main things this paper did. But it also gave you a glimpse just with 6 patients, so very small, series. It's not a big, large randomized prospective trial. This was an initial series. But what they did demonstrate was that, first of all, 4 of the 6 patients survived. And they also demonstrated they could do this pretty quickly. Now, again, these are people that have significant experience with using wires, using balloons, things of this nature. This is not, everyday, necessarily trauma surgeons at this point, or certainly not, ED physicians. These are fairly seasoned trauma surgeons that have significant vascular experience, but still pretty, even in that context, pretty respectable numbers here, 4 to 6 minutes getting the aorta control, and again, 4 or 6 of these very ill patients resolving or surviving. So again, they were able to do it quickly. They saw a significant increase in systolic pressure, so you had your outcome measure of improved, and a number of these patients survived. And importantly, they didn't have any significant complications from doing the REBOA. So that led to a wider or a more robust experience. This was one of the initial large papers which were published, or at least moderately large papers, which were published on REBOA, again by many of the same authors here, Holcomb and Scalia particularly. This is a retrospective review of utilizing REBOA between 2012, August 2012 and March of 2013 at Baltimore Shock Trauma and UT Houston. And basically they compared resuscitative thoracotomy versus REBOA. Now this was not a randomized prospective controlled trial. The REBOA versus resuscitative thoracotomy was done at the discretion. So again, you're going to have some selection bias in that, and it's a retrospective study. So not a perfect study, but again, more robust than the previous experiences. A number of these patients were in PEA, but again, you can see significant selection bias here. You have to recognize that. Only about 30% in the REBOA group were in PEA, 62% in the resuscitative thoracotomy group. So obviously the thoracotomy group outcomes are going to be biased against. We recognize that. The other patients were just in profound hemorrhagic shock, but not to the point of having coded yet. And what they found was basically that REBOA had a decreased mortality rate, but again, their patients were, less severely injured. But they also demonstrated that when patients died, REBOA shifted the place of death to the ICU. In other words, at least delayed things, to where, you had a chance of saving the patient. So again, more patients survived with REBOA, albeit that would have been predicted, but it could be argued on multivariate analysis, the survival advantage was still greater than that would have been predicted by the level of severity of the injury when they did the statistics on it. But also when patients did die, they died later in the ICU. Now, dead patient's a dead patient, it doesn't really matter where they die. But what that does show you is that there's hope for the future there, that if we can refine other areas of what we do, that utilizing that along with REBOA can hopefully help us ultimately to salvage these patients. This was kind of the algorithm they went with. In essence, basically, utilizing the zones to determine if they had isolated pelvic fractures, they would inflate it in zone 3. If they had, intra-abdominal injuries as documented with blood on the FAST exam, the focused abdominal sonography of trauma, then they would inflate it in zone 1. So this was just the algorithm they followed. I think really important slide here, though. This shows what the outcomes looked like. And if you see here in the patients that came in that got REBOA, this is just a REBOA subset here. The patients that were dead, none of them survived. So actually worse outcomes here with REBOA than with resuscitative thoracotomy, in that none of these patients survived. Over here, though, very respectable numbers with patients that had both zone 1 and zone 3, 75% survival in the zone 3 group, almost 50% survival in the zone 1 group. So I think this slide demonstrates what I would argue is a take-home message, is that I don't think we should think of REBOA as a replacement for resuscitative thoracotomy. I think we should look at REBOA as an adjunct to use in a slightly different setting. I would argue the setting for REBOA is that patient that's in profound hemorrhagic shock that you think's about to code but isn't there yet. Boy, you really don't want to cut their chest open because that's pretty morbid, But putting an A-line in and slipping a catheter up, that's a lot easier to, that's a lot more palatable, rather than cutting somebody's chest. And so I think a lot of times we lose, or a significant number of the time, we lose patients that we could salvage with resuscitative thoracotomy because we're hesitant to do it until it's too late. We wait until they code because we're so hesitant, because it's so morbid. But on the other hand, slipping a catheter up into the aorta, not something you'd want to have done if you don't have to have it done, but as compared to, if you give me a choice, catheter in my groin, and a balloon, as compared to whacking my chest open, I'm going to take the catheter in my groin. On the other hand, if I'm dead, I want somebody opening my chest and doing internal compressions because we know that's better than external CPR. So I would argue, as demonstrated by the data in this slide, I don't think we should think of REBOA as a resuscitative tool for somebody in PEA. I think we should think of it as a resuscitative tool to prevent somebody from getting in PEA. That's a significant risk for it. Some authorities would disagree, but that would be kind of my take on it and how I would visualize utilizing it. So again, in this paper, they they made the big point, Holcomb and Scalia and colleagues, and Dr. Moore, absolute contraindication, don't use REBOA in the setting of chest trauma or neck trauma. I would add to that the relative contraindication based on this data of cardiac arrest. I think somebody's fully arrested, I think I'm going to get an open to the chest. But if they're just on the cusp of it and stuff, then in that setting, I think this is where REBOA has a chance to shine. Now, as with any new technology, there were some hiccups with starting out. A significant number, even though in the skilled hands of Scalia and Rasmussen and others, there weren't any vascular injuries in that first series. Once this started to be used around the country, there were a lot of vascular injuries because this was a big-ass sheath and catheter that they were using at this point. This thing was 14 French. I mean, that's big. So that's something that basically, in most instances, they were needing vascular repair afterwards and sometimes even return, and I'll show you some data on that. They were using this huge Cook Coda catheter here. And when I went up to Detroit Trauma Receiving and got training on this a couple years ago, this is the catheter that they were using there at Detroit and at the University of Michigan. And I came away from that kind of impressed, but I just really didn't think they were there yet because you had to get a wire up, and they were talking about doing fluoro to determine where you're at, and you're blowing this huge balloon up, and then there's all this issue with the groin afterwards and stuff. And and then I started thinking about trying to do that here and how we're going to do fluoro and stuff, and I was just like, I don't think this is ready for prime time for us yet. And then, that highlights some of the others. I had to get the guide wire up. You really needed to do fluoro, or at least plain x-rays, which is a little bit unwieldy to do. And I think these were some of the things that plagued some of the early REBOA studies. And if you look, particularly in the Japanese literature, there's some pretty bad outcomes with REBOA initially there. But I think that's because of some of these initial limitations. And I think one of the other problems is I think we were looking at the wrong patient population here, looking at it as a resuscitative or last ditch when somebody's already coded. Again, as based on the Holcomb and Scalia data, I'm not sure that's the best setting for REBOA. So one of the first things which were addressed, and this is a study actually looking at this issue, small study that Holcomb did, published in one of the supplements in the Journal of Trauma and Acute Care Surgery. But here with the 14 French coated catheter versus a much smaller catheter, which we're going to talk about, 7 French catheter, difference in the need for vascular repairs. 0 vascular repairs with the 7 French catheter, 80%, almost a routine need for them with the older catheter, and 21% of those had to go back to the OR for a second repair. In other words, they had a complication. And so I think basically the development of a smaller catheter to be able to get a balloon up is a great step forward here, and Dr. Holcomb quantified that here. He also in this article talked about the importance of, in these patients that have very low blood pressure, it can be hard to get into the artery to start with. The use of ultrasound guidance, as you can see here, femoral vein, femoral artery, doing this under ultrasound guidance like we do IJ lines is, I think, going to be the standard of care for putting these catheters in. So Dr. Rasmussen, again, being a forward-thinking guy, kind of tackled this problem in his labs at the U.S. Army Institute for Research, and this was one of the early models. Sean, was this your guys' product initially? Do you know? You recognize this, or was this maybe just a lab line? So this was an early one, but looking at a much smaller sheath to deliver things through, and trying to get away from needing to use guide wires, to take that step out of it. So it started to look at, geez, if we can have kind of a floppy tip that's not going to poke a hole through the artery as you go up and get that in position. So this was one of the early ones. This was, I think he used this like 2011, 2012, published in 2013. And with that, they were able to demonstrate some reasonable outcomes, but there was still some downsides, so they continued to refine the product, and this is what is the current product, and I'll pass this around here, and this is what we're looking at bringing here, and this is what Sean and his company are marketing, and this is what basically Todd has developed out of his lab with some assistance from some colleagues and from this company. Again, key, it's now a 7 French sheath, so much smaller sheath, which again, less risk of vascular complication as documented by Holcomb and colleagues. don't have to mess with a glide wire, don't have to mess with fluoro. So it takes all those logistic difficulties out of doing this in the ED or even in the ICU. So this is more feasible to do. You know, when I think about doing this as compared to what they were describing at Michigan and at Detroit, up at Detroit Receiving, that wasn't feasible. I think this is feasible. I think this is doable. It's much more streamlined, much simpler. Essentially, basically, you have the patient, and you have to get in, basically, a femoral arterial line. That's your first step. And then you upsize the sheath slightly to basically 7 French. And then you just measure your catheter out. No fluoro, no guide wire. If you're going to aortic zone 1, you measure from the tip of the catheter down to the groin. And that's how far you push the catheter in. If you're going just for zone 3, if it's just for pelvic, you basically take the balloon, put it several centimeters above the umbilicus, because that's a wonderful thing about the aorta. As far as its external landmark, or God gave us this great external landmark, show us where the aorta bifurcates. Guess where your aorta bifurcates? Right at your umbilicus. So you know where, if you just want to put something as far distal in the aorta as you can, you just need to be basically slightly above the umbilicus. So measure your balloon here above the umbilicus, down to the groin where you're going in. There you got your length. No need for fluoro in order to do that, making it a much more streamlined process. So that gives you an opportunity to resuscitate these patients. Here's an example of what you can do with this. This again, Gene Moore still at it 40 years later after his initial call for restraint on resuscitative thoracotomies at Denver. Here he's doing a preperitoneal packing for a severe pelvic fracture, and in part of that, then they're going to also do a wrap, a T-pod wrap. But they also, because this guy was in so much extremis, did a endovascular balloon occlusion of the aorta, which you can see here. And here on initial angio, impressive amount of hemorrhage here coming from the external iliac artery distribution. You can see now hemorrhage completely stopped with the inflation of this balloon here in zone 3 of the aorta with the REBOA technique. And then here's what it looks like on subsequent scan. Here's what it looks like after they use a little bit different product than our T-pod, but basically accomplished the same thing here. And this patient was able to go on to survival. We're still lacking great randomized prospective trials, but it's being worked on again by Dr. Rasmussen and a number of colleagues around the country. There's this ongoing registry which is led by Joe DeBasse out of California. This is the American Association of Surgery for Trauma Aortic Occlusion for Resuscitation and Trauma Registry. And so far, they've been able to demonstrate basically, just to get to the salient points, that the survival seems to be improved with modern approaches. And this is not just REBOA, this is also resuscitative thoracotomy, basically in the algorithmic approach, which I'm favoring, or which I'm submitting to you. So 21% survival in this recent review from last year as compared to 7 to 9% in the past. Again, for both resuscitative thoracotomy and REBOA, if you know what you're doing, you can do this pretty quickly. And you get at least equivalent outcomes with REBOA in the proper setting as with resuscitative thoracotomy, both in regards to mortality and in regards to neurologic outcomes. But one of the points they make, and I won't read all of this here, but one of the big points they make is that one of the huge advantages of REBOA is potentially being able to do this before we would be comfortable doing a resuscitative thoracotomy. The point I made earlier that, maybe that patient is in extremis, but not to the point we're really comfortable cutting their chest. We are comfortable putting a catheter in to maybe prevent them from getting into that PEA arrest. And also, it's a thing of, the concept, and DeBasse has been one of the big guys to put this forward, is the potential for so-called partial REBOA. So you get the catheter in, don't even necessarily use it. If it looks like the patient is still stabilizing stuff, you've got the catheter in, essentially use it as a glorified A-line. Then if the patient starts going the wrong way, blow the balloon up. And then maybe you don't even blow the balloon up all the way. Maybe you blow it up partially. You partially occlude the aorta to slow down the flow, and decrease the amount that you're bleeding out of the abdomen and stuff without completely shutting off the blood flow. And there's a way you can basically transduce the pressure at the end of the catheter as compared to if you have a side port. So if you've used an introducer to put this in, you could transduce the side port. So now you're seeing differential pressures between, what's above the side of the balloon inflation and below, and you can kind of titrate the size of your balloon to that. So I think that's a potential for the future of, not an all or nothing thing necessarily, just having some partial, use it as a resuscitative, adjunct, if you will, while the patient continues to be dealt with. And there's a couple case reports. I think maybe you sent me the one recently where they had the guy in the ICU for like 40 hours with this in, but the balloon's not up the whole time, obviously, but a couple times, okay, they get the guy better, okay, bring the balloon down. A few hours later, oh, you're getting worse again, okay, so we go back up, with the balloon. And so I think this has a real potential to allow us to have more of a graded, if you will, response to the patient's physiology rather than the all or nothing of having their chest open with a cross clamp on it. And so I think there's a lot of hope in the future for improvement in outcomes with this tool. I think it is a potentially very powerful tool that we just need to get comfortable using, and it, maybe 10 years from now will be something that we use as comfortably as, central lines and A lines. But obviously, as with any tool, it has the potential for complications and for downsides, and so we have to be both educated and prudent in its utilization. So we'll stop there for this morning. Leave a few minutes for questions, and then I'm going to have Sean kind of go over basically, kind of the nuts and bolts of utilizing this with you guys. I think most of you here are from the ICU, where I would see this in the ICU setting again, is not coming to you with the balloon up for an extended period of time. You might see it, though, after we've done things, and we still have it in place. You might see it in a patient that we have to put it in if they start to go down. And there's other, trauma is not the only area potentially where this could be useful. I mean, there's case reports of patients bleeding out from obstetrical issues, placenta previa. There's a couple case reports without putting one of these up and the patient being salvaged, GI bleeding, other things where, the patient may be in extremis from bleeding from an abdominal or pelvic source. This has the potential to, I think, to help in the outcomes of our patients. Questions? Yes, Tyler? Yeah, great point. Zone 3 will tolerate more than Zone 1 will, certainly, because, you're cutting off supply to the kidneys and to the GI tract and stuff in Zone 1. Nobody really knows for sure, but the recommendation now is to not have the balloon up greater than 30 minutes in Zone 1 and not greater than 60 minutes in Zone 3. That's based on anecdote, but that's kind of the guidelines for right now. But great question, because you do start to have to pay the piper, for the ischemic burden that, and also something you have to be aware of if you have this type setting where patients had a cross clamp placed or where they have had a balloon up, there is always a little bit, or there's always a potential at least for a little bit of rebound acidosis. And so not infrequently, and I had to learn this early in my experiences in Iraq, where I would reperfuse an extremity, and particularly if I didn't waste some of that venous blood that was coming out, they'd get a profound acidosis. So I learned to kind of be ready for that and bump them with a couple amps of bicarb, for example, before. Or in other instances, I would actually bleed off. If I had a venous shunt in, I would bleed off some of the venous blood. Obviously, you don't have that luxury here in this setting. But you have to be aware of that metabolic hit that the patient's going to take once they reperfuse areas that have become at least transiently ischemic. But yeah, 30 minutes Zone 1, 60 minutes Zone 3 is it right now. Great question. Other questions I can answer?